I just wanted to welcome everybody. We are officially at the March 20th webinar on cash patients and cash doctors, and we're pretty excited to have everybody be here and let you kind of see where things are going and a lot of what we've got in store here in this particular series as it continues to roll out. Today we have a special guest. We've got Dr. Marilyn Singleton. She's the current president of the the Association of American Physicians and Surgeons. And she's going to cover a couple little topics as we kind of interweave what we're doing with Health Excellence Plus through kind of the realities of what that organization is up to and how it interferes with what the doctors are trying to get accomplished in improving their business. So it's a really exciting time for sure. Marilyn, are you there?
Yes, I am. Hi, everybody. I'm just so glad that Jeff is putting this series on, because people need to know things that they can say to educate the public and the patients, because many of us doctors know what's going on in the weeds, but a lot of the patients don't understand. In fact, I was talking to another doctor today who asked me, would I do something in her practice? And I said, well, I don't take Medicare. I'm opted out. And she said, what? You don't like old people? You don't want to help old people? And I said, no, I actually prefer free market medicine. And I think it was kind of stunning to her. But patients need to know some things that are going on. And so if there's any kernel anybody gets out of this that resonates with whatever your group of patients is, or clients of any kind, I'll just be very happy. AAPS was started back in 1943 when there was the first single payer bill, the Wagner-Murray-Dingle bill. And we fought very hard against that and kept on fighting against it all 14 times that the bill was reintroduced over the years in Congress. And of course, now we're fighting Medicare for all as not the best thing for patients. And that's why we kind of titled this, How to Put Patients First. We've got to get rid of the idea that the government or even third-party payers have patients' best interest in mind. We've certainly found with networks that the networks have the network's interest in mind, and definitely not the patient, how they leave them with bills and leave the networks really void of a lot of doctors and specialists that would like to join, but they have such low payments that the doctors aren't joining. So patients are the ones who end up suffering. So one of the things that right off that we do at AAPS is have a patients page. And on the patients page, it lists cash-friendly practices and DPC practices. And you can see Jeff put the page up, and there's links that the patients can click, and it's directed toward them where they can find doctors who'll take cash, and they can find direct primary care practices. And any doctor can sign up and get their name on there. And we also link to other folks who have such maps as well. Phil Askew's DPC Frontier, Twyla Braze's The Wedge of Freedom. And so patients have a lot of opportunity to find folks in their area. And we've had patients write letters back saying, wow, they never knew that medications could be so cheap. Medications that they were paying $70 for, they can get for a couple cents a pill direct dispense by their DPC doctor. Speaking of which, excuse me, one of the things we recently did was basically storm Texas, because they do not allow in-office dispensing currently. And so there's bills out there trying to allow that. And this, of course, all DPC doctors know that this is a prime part of that practice, being able to give the patients the medicines at cost. So we're hoping that that'll turn out in the favor of Texas physicians. And big pharmacy, of course, doesn't like that. They don't like being upstaged, but we know what's better for the patients. One of the things, and I began with this, is Medicare. And here the government is trying to have Medicare for all, when in fact, Medicare is not that great of a deal. And it has premiums, copays, and limitations on care. Things have to be deemed by the government to be quote unquote medically necessary. Well, who is it that is really deciding that? And the larger and larger the system gets, we don't know whether what's medically necessary is slowly going to be ratcheted down. And we'll find out the hard way. And we don't want to find out that way. And currently, we would like to see, if you have to have Medicare at all, which of course we do, people have come dependent on it, at least make Medicare more open. Make it easier for physicians to opt out, make it easier for patients to opt out. And we definitely have to get that legislation back on the boards that will repeal the rule that patients can't leave Medicare Part A without losing their Social Security. I can't tell you how many patients I've told this who don't know, and they're stunned when I say, if you decide you don't want your Medicare Part A, not only will they take away your future Social Security, but they will take away all the Social Security that had been collected in the past. Now, this is the sort of government coercion that we're trying to get away from. Because once you're trapped in the system, it's like the Roach Motel. Once you're in, you can't get back out. And that's what we don't like. A program might sound okay, but as soon as they want to change it, then the patient is stuck and the doctors are stuck. So we'd also like to see the same thing for Medicaid, where people, if they have Medicaid, and a doctor is signed up with Medicaid, for the patient to be able to go in and out of the system. There might be something that suits them better, and if they're willing to pay, let them. Don't tie people's hands. So one of the things that we do provide is a complete guide on how to opt out of Medicare. And it has the forms that you would need to fill out and sample letters that you have to send the patients, sample contracts of what you sign with the patient that gives all the government bullet points that have to be in the contracts. And physicians who have opted out have found this quite useful, and it keeps everybody on their toes. Now, one of the things that also we work for patient freedom is our lawsuit against the American Board of Medical Specialties for the maintenance of certification. We find that the maintenance of certification has just put a complete pall over some people's practices, that they can't expand, they can't do certain things, waiting for the other shoe to drop. And what next are they going to come up with this certification? And this hurts patients. There are a couple of physicians, and in fact, one who's a lead in our lawsuit, where because he didn't have MOC, he couldn't get the hospital privileges, so he couldn't even work in the free clinic that he was working at. And so consequently, tons of patients were without a doctor. And this is something that we just can't have. We need all the good doctors out there that we can. And then finally, one of the things we have to look at is how to get people to realize that you can do something about pre-existing conditions without having a government takeover of the whole healthcare system. Indeed, many moons ago, when we had a regular indemnity insurance system, there were multiple insurance products. You'll find this hard to believe, but just 30 years ago, there were 843 insurance companies that sold health insurance. some large, some small. And there were all sorts of products out there. Now the products, thanks to the Affordable Care Act, were squeezed down. They're all the same. They don't give people too many options. Thank goodness for these short-term plans and association plans that don't have to have the famous 10 essential benefits that some people don't want or need. And if we get a vibrant insurance market back, this will help folks with the pre-existing conditions, and the prices will be lower for everyone. So this is another thing we try to work on and let people know that there are solutions. There's health sharing ministries to join, and of course, direct primary care practices. And we need to make sure that opportunities for charity care are expanded. And again, there's plenty of charity care clinics. And indeed, one of the sessions at, well, I call them 1 p.m., 4 p.m. sessions that Jeff puts on, there is a libertarian group called We Do Better. And if you go to their website and click on healthcare, you'll see tons of clinics. And there's even a DPC clinic that I know of out here in California in Modesto, St. Luke's, where they are arranged, where they are set up as a charity. And so the paying members can add more money to what their subscription fee would be. And then the extra money goes to pay for a person who can't afford it. So they have a mix of both people who've paid and people who charity is taking care of their service. So there are ways, if we all know, we can unleash our own power and make sure that we do. Don't get cowed by the government. And don't let people tell you you lack compassion because you'd like to have a direct pay practice. Once they see the prices, they'll realize it's better off, not only emotionally, the patients have a better relationship, but financially. So that's my spiel, and feel free to ask questions.
Perfect. Let me unmute myself there a second. So that was very good. I appreciate that. And one of the values, and we're going to keep going here, but we'll kind of take a couple of little detours, is the vitalness of knowing what's going on legislatively, both from what we're doing as, you know, people out there trying to help people on their healthcare needs and costs, but obviously these patients. And so one of the things that we're really excited about helping to try to develop with AAPS is more membership from the consumer level, because, you know, they've done a fine job and they need to get more doctors, of course, but, you know, the doctors are kind of like low-hanging fruit, but the patients of those doctors really need to be aware of this, because when they put out, and she wasn't really mentioning this, but, you know, when we're on this alerts page, you know, just for a bunch of doctors to find out about needing to take some action on one of these alerts, it really needs those. One doctor could have 1,000 patients. Well, that 1,000 of those people reacting to this information is vitally important. So that's one of the key things too. You didn't really talk about that part, but I'm real excited about what that can bring to bear.
Well, thank you for bringing it up. I didn't want to bore you with too much legislative stuff, but we have found this to be an amazing tool. And what we've done with the action alerts, we'll write our own message that's more in the weeds to HHS directly when they ask for comments. And they ask for comments all the time on various rules that affect us. And then we'll write a sample letter for the doctor and or patients, depending on if appropriate for whatever the issue is. And we've had a really good response. I think our last one, you could see that it was directly from our website. There were over 400 letters that people wrote to HHS over, this was one of the rules with regard to drugs and drug shortages. So it is effective. And a lot of people don't think it is, because I admit, I know that it's us that matters, not the government, and we have to be the ones. But since the government is so involved in healthcare now, we have to get involved in that arena. And we've actually seen our name in the Federal Register on these comments. They'll say, AAPS commented that ... We agree. And so it's amazing to see the comments that you sent in have some effect on a final rule. So it does matter. And one of the things that we're looking for is informed consent on everything, all patient procedures, including vaccines, that nobody's against vaccines per se, but more and more that patients are walking into doctors' offices and not even signing a special informed consent paper, which everyone should. I wrote a paper a few years ago called Warning, Government Can Be Hazardous to Your Health. And one of the articles that I had come across was a vaccination program that they'd had here in Los Angeles. And of course, it was mostly poor Mexicans and poor Blacks. And it was a brand new measles vaccine. And none of the people had informed consent that it was experimental. And I don't know that people had any negative thing happen because of it, but the idea that they would do this to these folks and that they didn't even know it was a new experimental vaccine and not have informed consent. These things are really, to me, a crime against ethical medicine. And that's just one of the things we all have to push for, is always doing what's best for the patient. And sometimes it's hard for us and it's going to take more time, but in the end, we know that you always have to put the patient first.
One little last thing I'd like you to talk about for a quick minute is the reality of what they're doing to squeeze some of these doctors, that were forced to sell out to major hospitals, and then now they're not, going along with the new program of just maximizing what the hospital wants to do at the expense of the patient, like you said, to not be looking out for them, where they're doing these sham peer reviews and some of the more egregious of physical assaults that they're having happen.
Oh, yes, Jeff was at our meeting and heard some of the amazing stories. There is something, and some people don't even know the name, and it's now become a true name. It's been used in a court case, and it's sham peer review. And when the big hospitals want to buy up practices and doctors don't want to sell, there starts to be an all-out war against the doctor. And there may be some people who have seen this on the edges, whether it's to themselves or to somebody that they actually know. And they'll start pulling up all their old cases and whatnot, trying to get them off the medical staff. And so they have to move on. And this became a reality, and a lot of people really noticed it. We've been fighting against it for now several years. And in fact, our expert has gone international with it. He's spoken in Australia because the same thing is starting to happen in Australia, and spoken in Israel about this terrible process that's been going on. And I'm not ashamed to say, I used to be on peer review, and I feel like it was back in the day when we tried to be quite ethical about it. So we've got several cases pending, and we write briefs in support of doctors. We examine the case carefully, make sure that the person really is a good doctor who is being unfairly targeted, and try to help all these folks out. And we like to let people know, you've got to keep your eyes out. You've got to be aware of this disruptive physician label, because sometimes disruptive clearly isn't a negative. It's somebody speaking out for the patient. And there's a couple of cases where indeed our members won. There was one out here in California where she spoke out for the patient, and then they tried to get rid of her out of the network. So these things are out there. And a huge case really brought it to light in Houston. It wasn't our case, but it made a lot of national news. There was a surgeon in Houston who did a particular kind of robotic surgery that the other surgeons did not do. So they tried to drive him out and tried to find all these flaws, etc. Well, the court found that his peer review was, quote, economically motivated, close quote, and the fellow got several $1,000,000. And so this shows that this is a real phenomenon. So I urge people, especially folks that are going off and trying to do something different and trying to start a novel practice, people will be jealous. And you know, what can you do? Human nature is to strike out against somebody sometimes who's succeeding rather than joining in their success. They might try to get you in trouble. So that's one of the other big things that we're very, very involved in.
It's pretty insidious to see that happening everywhere, but that's kind of why it helps. Our mission is to save the doctors, to save themselves, in the end, save their own patients, because it's escaping really becomes the solution as we've all kind of come to that conclusion over time. We're going to kind of go into some of our stuff and cross-pollinate a little bit here, but before we do, I wanted to get a little bit more info out here, so we're going to take a momentary break. Charles, are you there? Have I got you there, Charles? I'm trying to get him unmuted here, or is he muted? There it is. Charles, are you there? Okay.
Yeah, there I am.
All right, before I answer any kind of questions, we kind of missed a little of the intro, so let's kind of just frame up what we're going to be doing these next couple weeks here coming up, and then why don't we go back into it with Marilyn? You can kick it off with a question.
Well, sure, Jeff, I can do that, or I can just wait till the end, because I do have a question on what...
Okay, go for that then. We'll switch it around.
Yeah, because, you know, I think to put it in context for folks, you know, this weekly 7 Eastern webinar series, Cash Patient, Cash Doctor, that we're hosting with leaders in the field like Dr. Singleton, is both about our plan to empower patients as cash payers, which helps the doctors innovate, but also with the big picture discussion by the guests like Dr. Singleton. It's one thing to empower a patient or a doctor, but we do have to advocate for a more free market so we have more choices. And I wonder, Jeff, Marilyn, if Jeff could look at your consumer page one more time to show where our cash paying members can find doctors who want cash paying patients. I think that's a good section to highlight. And then
scroll down some.
And then to elucidate a bit more on that Sham peer review, isn't it also not just about jealous doctors trying to sham peer review a maverick good doctor out of a job at a hospital, but it's also getting the gangs at the medical board that the state uses to enforce conformity among doctors? Isn't that also a government threat to the doctors?
Yeah, it is, and each state is very different, and of course some states are harsher than others, and they can pad their medical board with like-minded people, and it can be a real problem. Our California Medical Association used to be very pro-doctor, and there's a subset in the group, a California Solos group, that year after year, they're just looking and saying, we belong to the Communist Medical Association now. It's just totally shifted to this whole idea of we're just going to lay back and accept single payer. And we have got to stick together to fight this idea that that is what's best for the patient. It's one of those quickie, easy way outs where it sounds good, but it's not, and you find out too late. And this is what bothers me about it, that people will be stuck in a system and there won't be a way out. As many people may know, one of the hallmarks of both the single payer plans is that all private insurance is abolished if it covers any of the same things that the government covers. And basically, when you look at the list of what the government covers, it leaves plastic surgery. And who would get insurance for that anyway? So basically, there is no more private insurance. So this would be far worse than the Affordable Care Act, where at least there are private insurance companies out there and they could be molded to fit newer situations or more free market situations. But if you got rid of the insurance industry, what happens when single payer fails? Everything will have to start from scratch? I doubt it. People would be left in the lurch, or be left to have the rationing and all the other parade of horribles that we know happen with these sorts of systems. So we all have to be vigilant, and it is one of the reasons. Another thing we do is and this is something I curate, a legislative update to try to keep people up on what's going on in Washington. And they slip some of these healthcare things into other bills. And the big bill that's out there now, HR 6199, we don't know whether it's ever going to come up again. And this is the bill that addresses HSAs, uses for the HSA. And I know we free marketeers love that whole health savings account concept, and trying to get HSA to be able to pay for DPC. So there's a lot of stuff out there that we have to keep abreast of, and that is what we at AAPS try to do with these alerts, again, to get the population involved and to get the patients involved. And education, that's the biggest thing. We've got to let everybody know, not just this small cadre, but get the word out there.
Very, very good. I was going to say that's kind of the reason behind these calls, and kind of having a chance for others to find out about this and band together, because as many have found that, like those organizations that are doing those sham peer reviews, those type of entities and those people, they all meet all day, every day to figure out how to get over on everybody else. But that doctor that's just trying to advocate for their patient is really pretty preoccupied running their practice than to be engaged in any of this nefarious activity. So it is critical to know about all these separate things, and then again to get to that consumer out there, because they're really leading the charge. Like you said, when enough people write a letter to their senator about something, that person pays attention, even if it's a fairly small quantity of people, but they're noisy and they're in that person's face. So it really allows them to have an excuse or a reason to take action. And more often than not, they want to do the right thing, but they'll go wherever the lobbyists lead them. To shift a little bit before we kick into some other stuff real fast, let's kind of take a look at how some of this ties together here, and you'll sort of see where some of this plays between what we're both trying to accomplish and how we can kind of fuel each other's fire a little bit here. And first off, I have a little disclaimer here, because for sure we're just going to do a little skimming here. So this doesn't replace a full presentation. You're going to want to read all the program documentation and make sure this is a good fit for you. Do follow up with the person that directed you here to get the full breakdown on every feature in this program. They'll make sure you are selecting the right version, and then it will be a great fit for you. Every week we'll be explaining the way Health Excellence Plus pulls your whole healthcare world together with the help of a variety of medical professionals, medical association leaders, industry leaders to keep you at the front edge of what's happening in healthcare today. And as you can see, that's exactly what we're executing. And so here's what we're solving, though. So you'll sort of see what Dr. Singleton was describing and kind of what we're doing. And feel free, Dr. Singleton, to chime in on any of these aspects here. But we're really solving the big 6 problems. And of course, there's a big shopping list of problems, and everyone's got unique problems. But these are pretty common ones. The increases in the cost. I'm paying and paying and paying and paying, and what am I going to get in the end? What if I never get sick or have a physical? That was a very expensive thing. At least in the end, I may own a car or a house, but here I'm spending all this money for nothing in the end, and potentially. No rewards, there's no incentives for the patient, or even for the doctors for that matter. In fact, the only incentive for most doctors is to wait for you to get sick so you come in and spend some money with them. And then what you were mentioning before about those networks, deny both the doctors. We think of it from the consumer side always only, but you can see how it's both sides are messed up in what's happening in here. Medical records all tied up, and then all the time that gets wasted, and then nothing's personalized because the doctor doesn't have time to. They're running on a little 15 minutes next type of a track. Would you say that covers the large measure of them, Dr. Singleton?
Pretty much so. Pretty much so. One of the things that I think that we all have to really pay a lot of attention to is the idea that outside people are making the determinations of what is necessary for the patient's good care. And that's starting to be a real problem as more and more of these guidelines come out, and it's like, where did they come from? Who wrote them? And there was recently an expose that the folks who were writing the guidelines had actually received money from the drug companies. That's why suddenly everybody's on Lipitor and various other drugs. And not that there's not a place for it, but let's not put it in a guideline that was fueled by the drug company who made the drug. And this is this whole thing when you talk about not personalized. And this is the most important thing that we're starting to get away from in healthcare, is that treating the patient like an individual, treating the doctor like an individual, that the doctor can run the practice the way they want to run the practice, as long as it's safe for the patient. And the idea of squashing innovation when the innovation isn't in the direction that the government wants it to be is just antithetical to what makes us good doctors. We have that independent spirit, and we always want to do what's best for the patient.
Absolutely. And you know, one of the things you're right about too, when everything gets very singularized and codified and identified and, you know, carved out as a set thing, innovation typically terminates, because there's no reason to innovate anymore. We've all settled on this being the norm, and we live with it for, you know, years to come, even though technology's moved beyond that. So here's kind of what we're trying to do. We want to solve all that. So we've got a variety of programs, including one just for DPC doctors. Also wellness and concierge services, meaning that you're going to have someone to assist you finding better medication pricing if need be, or getting a better price on an MRI and whatnot. The idea of having preventative, which could ideally be provided by that DPC, or, you know, through one of the MECs that we still provide for the people that need to go that route. The idea of having 24-hour-a-day doctor, what a great innovation that is. It's stifled in so many places, where I can not clog up the emergency room and not waste time at an ER urgent care center or try to chase my doctor around, when I can just call a doctor 24 hours a day. You see a lot of growth in that, I'm going to assume, right?
Mm-hmm.
It's just a great link, especially in rural areas where doctors are sometimes a little sparser. And then, of course, medical.
And one thing, Jeff, I have to say with that, when you talk about the 24 hours a day, some doctors were worried in the beginning in starting programs like that they'd be barraged. And it turns out the patients are so happy with the doctor and respect the doctor so much that none of these folks are having people abuse that privilege. Just none of them have complained about that.
No, in fact, we had Dr. Cordney on the call the other time, and he told a patient, you know, you can call me in the weekend. They said, no, doctor, that's your time. I'm too respectful to bother you on a weekend. So unless they're like deathly ill or something, they do respect it. So yeah, there is no abuse when people have a good relationship with each other. But if I have an insurance thing and I've spent a fortune, I'm out there trying to get anything and everything I can get out of that thing to get some of my money back, even if it's about a sham what I'm engaged in. So absolutely. So then there's the medical cost sharing, which will include anything that if you end up in the hospital, which is great for the doctors that really don't work inside hospitals. They're there to help you on a primary basis. And then the idea of medical tourism, and we're going to have some guests, Charles will talk about in some coming weeks, that you want to maybe go to for some surgeries and so on. And the fact that you can work in some different treatment modalities, help someone to help you get these bills negotiated. And then most importantly, like you were mentioning, the idea of health savings accounts, and we've got some other tools as well. So it makes for a big difference. So, but this is what we've sort of isolated out as the way we've approached the market space, is that there's really a strategy required. Just buying a car doesn't get you to California. You need a map and gasoline and where am I going to stop and stay, and I need a plan. So that being the case, this is the strategy that you really need. And what most people are focused on is the one at the bottom where it says contain, because that's like, what if I have a heart attack? So yeah, that's important, but remember what Dr. Singleton said years ago, there was a thing you could buy just for that. Now you've supposedly got a bunch of other stuff that are supposedly covered, and I'm paying $1,000 a month and $5,000 deductible, and in some respects, I'm almost a cash pay patient because I can't get service from anybody until I spend a bunch of my own money. So it's totally broken, and again, it's all based on sick care. So we're realizing, as most of the world has woken up to this, the idea is you want to avoid problems in the first place. I mean, that's why I have all those sensors in my car when someone's getting close or I'm backing up too much. Same sort of thing here. So in that instance, we're going to kind of fulfill that with a variety of tools. You're going to have your ER card, which is a special membership card that goes on your wallet and also on your keychain, and has a special patented QR code that first responders can read. It's got all your medical records. And I'm going to want you to talk about that for a quick minute, because the idea of having your medical records is almost like a fallacy in the current world, because no one seems to have their own records. My records are a little bit over at this doctor and a little bit down at this hospital and so on. And our system allows all those separate elements to dump all those records into one single place. So if you go to a new doctor or on the road or traveling, you literally have all your records from the day you were born, if you're inclined to today. And, you know, talking about that for a minute about medical records, because, you know, you can really address well about the idea of HIPAA and like what Twyla's doing, where she's got the non-HIPAA doctors and so on. Why don't you mention a little bit about medical records and HIPAA?
Oh, golly. This whole HIPAA thing is now actually, there's new changes coming and another campaign trying to make sure that we have the separate standard for drug treatment and psychiatric records, mental health records, because they've always been held sacrosanct, where they're more difficult to get a hold of. And there's always one case that makes the legislators come up with an idea that turns out not to be so good, where there was someone who had a history of drug use, but it wasn't in the records. So they wanted to have all records opened up. And this is where what you're discussing comes in handy, because at least it's a record that stays with that patient. It's not one of these records where I feel like they're out there on the open market and anyone can see them. They're constantly hacked, and we just can't have that. And so this is something else we have to keep abreast of. One of the DPC doctors, Kim Korba, is starting to give webinars on HIPAA, because that's starting to be so complex, of who is someone who has to be in the system, out of the system, what things are required and not. And so many things that patients don't know are things that automatically can get transferred from one person to another without written consent. So there's a lot of stuff to keep up on, and thank goodness for Twyla, because she is so on top of all that and all the rules, and they're changing right under our nose.
And which is why it's important that we stay abreast of it. And so, you know, typically people are so busy to engage in what they're doing just in sales activity or whatever. There's no time to know about all these separate things. And so that's critical. What we're trying to do is consolidate it down so you're really able to get a handle on that. Sorry, I got a little thing going, making some noise in the background. I'll shut off. Then also the idea of having a health risk assessment, and we've got a couple levels of that, and we'll dig into that in these coming weeks. But the idea is you need to figure out where I'm at. If I use my analogy before going to California, I have to know where I am this minute to know how to get to California. And so the idea of this risk assessment is I'm going to get an assessment on where I'm at today and build a plan to avoid needing to get to that containment feature. I'd rather not figure out how awesome my insurance is because I have this unbelievable heart attack and all what they do for me. I don't want to have the heart attack in the first place. So that's the whole idea of having that. And it's critical in today's world, because, again, it's flipping it back to the old day. The doctor was there to take care of you, largely in a preventative methodology, and then it morphed into, like, you know, you only come to me if you're really sick, otherwise don't come in at all. So it's the wrong approach, and that's why doctors can't stand it either. And then prevention. So here you're going to want to, you know, work with your doctor and do whatever testing and all the rest of the things that entails. And, you know, your cash paid doctor is going to be able to do different things for you than a different kind of a doctor would do. But we're going to be able to mix and match as far as that goes to fit right in there for you. And then this concierge is an important part, because then you want to manage, and, you know, who has the time to become an expert at everything? So you want to have somebody that can really help guide you through a lot of different aspects. So that's the idea of having a single number on that key fob card, that if something comes up, you call that one number, and they may say, oh, you need to talk to a doctor this minute, and boom, you're talking to a 24-hour-a-day doctor. Or I'm needing to get a medication, a much lower price type of situation. And that's where they're going to shift into the mitigate part. And that's where we're going to, again, have that 24-hour-a-day doctor, which, again, either is provided by your doctor or we're going to back that up. Second opinions for if you're being told you might need some surgeries, you're unsure of whether you really need those or not, type of thing. So we're going to let you be able to get a second opinion, and that'll be a benefit to you. And also we'll reduce some of your potential costs just by taking it, because we'll lower what you would pay on a out-of-pocket basis for getting that second opinion. And then there's a big one for a lot of people is the idea of global access for medications, because some medications, once you go past a certain level of tiers in your insurance policy, typically the drugs are, at whatever they sell at retail, and some of them could be thousands or $800 a month or some astronomical figure. But lo and behold, that same medication might be able to be had for, say, $100 from some other country. So we're going to help facilitate that for the consumer. And then the medical tourism is a great example. I'm here in Cleveland, and Marilyn, you can talk a little bit about this. I would appreciate that. I'm in Cleveland right now, and we have the Cleveland Clinic, and it's a monster, and it's world famous and every other kind of thing. But yet I could go to the Oklahoma or the Texas Surgical Center and get the identical surgery for 1/10 of the price. So as an informed consumer, and I'm going to get better care because it's more of a boutique, hands-on, as opposed to a machine like they have here, where they just pump you in and out of there and never see a doctor half the day laying in that bed in there. What do you see is happening with medical tourism? I mean, it used to be just people from us going to Mexico, but now we got people coming from other countries to the United States.
Oh, absolutely. And, you look at the Oklahoma Surgery Center, there's a few in Texas. We have a couple out here. The prices are posted online. And again, there's other websites, and we refer to those websites on our cash practices. It's unbelievable. Now companies are sending their patients to these cash-based surgery centers rather than use whatever insurance policy. And self-insured companies are definitely doing it. And I know of a small company that is self-insured for the basic stuff, and they send their patients to a surgery center for elective surgery, and they have reinsurance for really big ticket items. And again, this comes into this whole idea that you need an array of things. You do need insurance for some things. You need direct pay for some things. You need someone to help some patients out who can't seem to manage their care at all and never take their drugs and all that. So you do need kind of these coach type people. Everybody doesn't need that. So this whole idea that all patients need the same thing is just ridiculous. And that's one of the things that keeps the costs up.
It's scary because when you said that comment, that is the reality, what you described. Because look at all, we know one thing could be for everybody. So look at all the nuances we've just run through here already. Look at all the diversity that represents. How in the world can some group of bureaucrats sitting in a room concoct some one-size-fits-all mentality? I always joke, look at how many kinds of coffee are at the grocery store. We can't even settle on one kind of coffee. So, it's a fallacy. And then lastly, just to wrap it up, is the idea of containing. So this is what everybody initially shows up with. Oh my gosh, I got to get rid of this other thing over here. It's costing me a ton of money. It's bigger than my mortgage payment. And I only got it in case I have a heart attack, get hit by a bus, any number of horrendous things. But it's not about any of the rest of the stuff we've listed here for the most part. And so they just kind of rush over here thinking, well, I got to get rid of that and get this because it's lower pricing, which it is. But that's not the reality of what they're abandoning. They're coming into a more complete world for those where this fits. And one of the things that keeps that cost down is the idea of medical cost sharing, where we've all kind of banded together to share each other's costs. But as a consequence, we sort of have that skin in the game. So it's like, well, wait a minute, I don't want to get the overpriced MRI when I can get it the same one and better, cheaper right here, 6 of one, half dozen the other. But yet that's going to keep the cost of this thing I'm doing here lower for myself and for everybody else that I'm hooked up with in this group that's trying to make this happen together. So it makes a lot more sense by far. It's much more ethical. And to kind of take it a little further, how we make it a little bit different, let's take a look at a little bit of the differences here. And that's the idea of the fact that it is based around a need. And then also just to make sure that everyone is aware that this is definitely not insurance, and it's something that we're really excited about because we've already sorted out by our discussions up till now that that doesn't work so well. So The idea here, though, is a little different. In a normal insurance world, or even a lot of sharing worlds, you kind of got to get up to a certain amount of money out of your pocket before the thing kicks into gear. With our scenario, using Sedera, it doesn't require that. You just really have to have one thing happen, and that's a complete need. So if you broke your leg, that's a need. If you had a heart attack, that's a need. So if you set yourself to pay either from between $500 or $5,000 as you're a part of that bill, then that controls how much you pay per month. And then it's limited to 3 needs. So there is a line in the sand. So if you had that $500 version and you had a broken leg, a heart attack, and a car accident all in the space of 6 months, the most you'd be spending is $1,500. And then if something happened after that, then you wouldn't pay anything because it's inclusive in the sharing. You've already met the obligation of 3 of those. And then the other bigger difference comes down to the idea of prescriptive drugs and look-backs in terms of pre-existing conditions. So these are only little differences. So in the prescriptive drugs, if you come with one of those needs that I just described and you have your heart attack and a whole bunch of things happen, you're finally all cured, the doctor says, go home, don't ever come back. But I want you this one pill from now on. We'll pay for 120 days of that, and then after that, you're going to use those tools that I talked about a moment ago to get that at a very low price and either just pay some cash for that because we're saving you hundreds a month, or you're using your HSA as an example. And then the other one would be with the pre-existing. So in that instance, in the first year, we'll take everybody that comes to our door, even if they have a health issue, but let's say they're in the middle of chemotherapy at the moment. In that first year, we're not going to share in any of the costs of anything that's a pre-existing condition. So that won't screen out the type 1 diabetics of the world and so on, but it will kind of stop somebody that's that severe. That's the person where some other health obligation is going to be beneficial for them, insurance or whatever else that they're taking advantage of. So again, we're not going to be for everybody, but we're going to be for an awful lot. And we're for individuals, for groups, for businesses, for doctors' offices and their patients. So we fit an awful lot of people there. And again, for more information, you're going to want to follow up with any of the people that were on here. We're going to want to open this up for questions in a moment. But before we do, Charles, if you would intercede for a moment, because we want to just announce what's coming up in the next several weeks, so you can kind of put this on your calendar and promote this out to people to be participating and attending.
Well, thanks, Jeff. This is Charlie Froman. Can you hear me, Jeff?
I can hear you great.
So we have, as Jeff mentioned, a great healthy care strategy, not just for families, but also for businesses and associations. And we have lots of partners promoting us. One of those partners is a membership group called Liberty International. And their president, Mary Ruwarts, will co-host with Jeff next week using her classic book, Healing Our World, which is full of prescriptions for health reform. So we will discuss our health solution, but in the context, as usual, with whatever the co-host is preaching. And Mary Ruwarts is a former biomedical researcher, has another book called Death by Regulation about the FDA. So it's going to be a night of big health reform issues. After that, we're going to have another leader doctor like Dr. Singleton. This is Dr. Legrelius from the American College of Private Practice and Association of Independent Doctors. So he will discuss not just DPC, but concierge practices. He's been doing it since the 2000s, an old warhorse on cash paid practice. 3 weeks from now, we will have the inventor code that Jeff mentioned and Dr. Singleton praised about coordinating all of our medical records on our membership card or key fob. Then we'll have another leader among doctors, Dr. Leah Houston, who has her own doctors organization and is big on the blockchain. That'll be an innovative effort that folks in the technology will want to hear about. And then Dr. Charles Benz with the Artificial Intelligence Functional Assessment, Tony Dale, the founder of our sharing partner, Sedera, and then Sean Kelly, who runs that Texas, as I mentioned on this call, that discloses the prices and really facilitates medical tourism. And so we're full all the way through the end of May. So, come back every week at 7 p.m., Jeff, and everyone on the call.
Excellent. Thank you very much for that. And again, Dr. Singleton, I appreciate that. Did you have any last comments you wanted to make? And then we'll just kind of close it out with some questions here with a few minutes left on the clock.
Oh, I'm certainly fine. I'm glad you went over all these issues that are facing all the patients, and we are all just trying to do our part. And again, it's up to us. It's not up to anybody else.
Yeah, sadly, that's always the case. Everyone's so eager to try to let someone else try to solve their problems. And then all these calls, as we've been doing earlier in the day on this more broad topics, it always comes down to the person having to do with it for themselves. So it's up to us to really help everybody else, help them figure out how to help themselves. And these are the tools that'll make it happen. What we've got going on, membership in an organization like this where they're reacting to these alerts. And so we're going to have a nice time saving America together. All right, we've got some time, so let's grab some questions. If anybody would do me a favor and just kind of raise their hand here. I kind of had to mute some people. There was all kinds of background noise happening. So if you use that little hand raising emblem on the side there, I will unmute you. Rod, I have you unmuted as it turns out. Would you like to make a comment while you're waiting for others?
Yeah, this is just kind of a statement. Thank you, Dr. Singleton. This was really excellent, a lot of great information. I was reading yesterday about John Hopkins getting into the direct primary care arena, and that was really surprising to me, as some of the big boys, you know, the biggest boy, if you will, or one of them, you know, beginning to understand about this disruption that needs to take place. Now, so far, I understand that it was just opened up in January, and for their own employees as an initial test. But any comments on your part, Dr. Singleton, about some of the bigger players in the industry seeing the value of these programs and joining in?
Well, yeah, it's interesting. I used to teach at Hopkins, and I have to say, Hopkins is a very innovative place. And yes, it's a big boy, but there were all sorts of little things they used to do there that I hadn't seen in other big organizations, and certainly not in the hospitals where I had done my residency. University of Michigan, probably, I guess, a year and a half ago, had started their own DPC-like practice. I haven't seen the follow-up on that. And, you know, it's always one of those things about will the big boys ruin it for everybody? It's like the government is trying to start a DPC innovation thing, but the problem is they're missing the whole point. They want the government to pay the DPC fee. Well, what's the point? The whole point is the patient.
Right.
But anyway, so I do have high hopes for Hopkins. I've seen other kind of on the edge things that they've done succeed quite well. And as long as they keep it in the same spirit of what DPC is supposed to be all about, I think it could be very useful.
Tonight we're also being joined by Dr. Tinsley. He's an acquaintance of Dr. Cordenoy, and I see you have your hand raised.
Yeah, thank you. I just want to thank Dr. Singleton and AAPS. Can you guys hear me okay?
I hear you great.
Okay, great. Wanted to thank them because about 4 or 5 years ago, Dr. Orient heard me ranting online, or saw me ranting online, tried to get me to go cash back then, but just wasn't possible because of my non-compete. I'm finally going DPC now, and
you're
formally
formally
give you a hand over the internet.
And you're formally with the VA currently, right?
I just quit the VA, and I'm finally getting my sanity back.
That's a little bit of Medicare for all, right?
Yeah. Oh, listen. Yeah, that is a true Medicare for all system, and I've said this last time we were online, is that the VA is the Medicare for all system, where they say Medicare for all, it's not going to be Medicare for all. Medicare only survives because it works within a private system, and it's supported by private hospitals and funded by the shortfall is made up by private insurance. The Medicare for all system is going to be more like the VA, where patients had a 3-month wait just to see me, and even longer to see a specialist.
Wow, that's sick. Just
sad.
Yeah,
How long did And is it a good example? How long did it take for the VA to fail, from when they started to when the log jams began to appear?
Oh, listen, I was there for a little over a year, and I was working 11 to 12-hour days, no lunch, and 2 bathroom breaks. And I had 2 people in the administration tell me that wasn't good enough, and I had to do more work at home.
Sounds like a heck of a career move there. Amazing.
Yeah.
Well, congratulations. I'll have to tell Dr. Orient.
Thanks for coming over to the dark side.
Yeah, listen, it was Dr. Orient that I was chatting with online, and it was a couple of years, I don't know how many years ago, but listen, yeah, please tell her thank you for me. And I used your on-site letter for opting out of Medicare, and I passed that on to somebody else that was looking for a way out as well.
Oh, well, thank you. I'm so glad it was helpful. And believe me, you'll love the transition. And people are afraid in the beginning because at first you think, oh, how, am I going to make enough money? I won't have as many patients. But you turn out that life is good.
Well, I just want to say one other thing.
Go ahead, please. Close this out.
The corporate DPC that you all were talking about earlier, it's not DPC. The whole point of DPC is that we're working for ourselves. We're not beholden to an employer, and we're not beholden to the government for a paycheck.
Well, that's exactly what we need to make happen. So that's why I said, welcome to our side, and it's a race in certain respects. And so we're really, developing this series, and all the people we're working with to try to be the winners in that race, because our personal lives are on the line. Frankly, it's not just about money. One of us is going to need to see a doctor, so it's pretty critical.
Yeah, Johns Hopkins can say they're running a DPC practice, but they're really not.
Well, let's hope they don't ruin the concept for everybody. That's all I can say.
Yeah, that's the biggie right there. Well, that was great. I appreciate everyone being here tonight. We'll reconvene next week with another exciting event. Look for a video of this to come out, so you'll be able to circulate this and invite others. And again, everybody that registers for this will continue to get these ongoing. And again, just as a reminder for those, I think I failed to show this, but for people that you want to be participants in this is in fact the link to give out, bit.ly/cashpatientwebinar. And that'll register them for this on a permanent basis. Just by registering, they're going to get those videos until they unsubscribe. So thanks, everyone, and I'll see you in a week.
Thank you.